Well, hello, and thank you for joining me for the time that I get to take to talk a little bit about one component of implementation science, that of barrier assessment. I want to recognize those who've put so much work into making this conference happen, especially Mary Slavin and Linda Resnick for their leadership and work, and I appreciate those who are conducting and participating in this session today. I also want to express my gratitude to my home institution of the University of Nevada, Las Vegas, and the physical therapy department that supports me, and Johns Hopkins School of Medicine, Department of Physical Medicine and Rehabilitation for the opportunity that they give me to partner with them as an adjunct professor for the research that I do. And the examples that I give and the discussion today is going to be centered around the work that I do with them. So I think it's critical before I get into the direct issues of barrier assessment and how we do that as part of some of the work we're doing, to lay a bit of a foundation for the larger context of that work. And it lays on a foundation of this principle, that bed rest, immobility, inactivity, that those things are physiologically harmful. And we've known that for a long time. You'll notice that the second article was published in 1944. The first one I've listed here was originally published in 1967, republished in 1990. All of these talking about how physiologically harmful it is to be inactive and immobile. And yet, despite our knowledge on that, back in 2004, some of the leaders that we have in this area of low mobility for hospitalized people, particularly for older adults, Cynthia Brown and Sharon Inouye published this piece where they measured a cohort of patients in the hospital and observed that nearly half were in low and intermediate mobility groups, that decline in ADL function during hospitalization occurred in just under a third of those folks, that among that cohort who came in previously living at home after leaving the hospital had to go to an institution, typically that's a skilled nursing facility, and that 7% of these folks died during hospitalization. That combined death and new institutionalization group of 22% seems dramatic, and we are learning more and more about the ability of medicine to treat the medical problems people have that they come to the hospital with, but that this immobility and activity really makes it hard for them to sustain those gains, and that secondary problems occur because of that. Now, in this cohort study, they saw that a third of patients had bed rest orders, and that 60% of those were in the lowest, of those bed rest orders, almost 60% in the lowest mobility group had no documented medical reason for it. So a lot of people are told to stay in bed when they get to the hospital, and there doesn't seem to be a reason for that happening. This same sort of observation was repeated by Cynthia Brown in a second study a few years later in 2009. This was an older cohort of patients, again, who came into the hospital. More than 3/4 of them were willing and able to walk before coming into the hospital independently. But when they looked at what happened to them while they were in the hospital, 83% of their time was spent laying in bed. And only 3% of the time that these patients spent in the hospital was out of bed or walking, which was about 43 minutes out of a 24-hour period. That is really concerning. This final paper that I'm going to use to kind of lay this foundation was published by Ken Kavinsky. He's done some important work in the same area looking at hospital-associated disability because of immobility and inactivity. And in 2011, he noted that hospitalization-associated disability occurs in a third of patients over 70 and is often triggered even when the illness that caused them to come to the hospital was successfully treated. And so we really need to think more carefully about activity and mobility in the hospital and the harms that it causes. Now, there have been some efforts, mostly by a few small groups, but there's gaining traction. And there have been a couple of social media campaigns and grassroots efforts to try and raise awareness and move the needle globally And the Hopkins folks with their Everybody Moves campaign have been really important leaders in the United States with that effort. And you see on the left, one of their posters as part of this social campaign. There has been a virtual conference. Another one is planned in this regard, and a lot of activity on social media, particularly Twitter, using that hashtag Everybody Moves. In the UK and in some other international locations, there is a group that started this End PJ Paralysis campaign, very similar in their efforts to raise awareness for hospital-associated immobility and activity and the deleterious consequences of that. So a couple of grassroots campaigns, more social campaigns that have been done. I want to narrow in on a more systematic approach that is targeted and evidence-based related to combating this immobility harm in the hospital. The Johns Hopkins Activity Mobility Promotion, that we call AMP, is one such program. It's an interprofessional program designed to support both the hospital and the providers in that hospital who want to change the culture of patient immobility. It comes with tools and education and training, and I'm going to be talking about the development and one component of that related to barrier assessment today. This paper, this model that's on here, and you know, as implementation scientists, you all love your models, and so do we, right? We all have our favorite model that we use to do implementation science. This one published by Peter Pronovost and Sean Barinholtz and Dale Needham in 2008 was an effort to give healthcare providers in particular a model for knowledge translation at scale. So in this case, we know that bed rest is bad. We know we need to change practice and behavior. And so we follow this model to help us to do that as we implement AMP in an organization. You can see that this model needs to be seen within the larger healthcare system and organization, and that we have to engage multidisciplinary teams in a collaborative way, both locally at the local hospital, but also the local unit, and centrally that the administration needs to buy in and have this be a priority as well. And this model has just these 4 steps, starting with summarize the evidence, which I've been doing for you so far in this presentation, identifying local barriers, which is where we're going to focus in, measuring performance, and then ensuring that the patient receives the intervention through a cyclical process of engaging, educating, executing, and evaluating across both patients and families and the providers at the institution. So now I'm finally getting to the barrier assessment part, but hopefully in the framework of the AMP program, this will make more sense now as I talk about it. And one key principle to this idea is that all politics are local. We've heard that quote before, and it's true when it comes to barrier assessment and getting buy-in when identifying and trying to ameliorate actual or perceived barriers. This needs to be done in your institution, at your unit, and it doesn't help to make assumptions about what you think the barriers are going to be without talking to the local staff that you're trying to get to change behavior. And we feel like a systematic evidence-based approach to barrier identification can make this even more effective when it comes to moving the needle in practice. And I'm going to provide 2 examples of how we have done barrier assessment as part of the AMP program. The first was conceived as we were putting AMP together as an organized program with the idea that we're trying to change practice. And this paper was very helpful in that overall understanding and framework. This article about why physicians don't follow clinical practice guidelines, a framework for improvement, identified some key areas, at least for physicians, that we felt like would translate to other healthcare providers just as well. And that is that we need to know what people know, what they think and feel, and then we need to try and change those things such that the behavior that we're measuring and observing can also change, and that these 3 things go together. We need to know where people are at the beginning, in order to move them to somewhere different. And that if we are putting this in the context of barriers, that we are looking at knowledge, attitudes, and beliefs about activity and mobility and the barriers that could be a part of that. And so Eric Hoyer led this project early in our efforts to systematically organize AMP as a program, and felt like that a survey would allow us to do this at scale and to do it repeatedly. And so this survey was developed covering the knowledge, attitudes, and behaviors of clinicians relative to activity and mobility promotion in the hospital. And each of the questions in these areas is answered on a 5-point Likert scale from strongly disagree to strongly agree. And there was also some psychometric testing that was done once the survey was completed. Now, on this slide, I just want to give you an example of some of the questions that are there. You can all get this paper, of course, and read all of the questions, but I think it'll be helpful to think about them in this presentation if I just read one example from each of these 3 domains. So in the knowledge domain, one sample question is, I understand which inpatients are appropriate to refer to physical therapy. Again, answered on a strongly disagree to strongly agree 5-point Likert scale. That's true for all of the questions. In the attitudes domain, an example question, I do not feel confident in my ability to mobilize my inpatients. And in the behaviors domain, unless there is a contraindication, I mobilize my inpatients at least once during my shift or work day. And this barrier survey, I'm going to talk about how we utilize that and how it fits in with an implementation structure for an entire program like AMP. But I want to give one other example before I do that. The other way that we've done barrier assessment, this was a project done in the medical intensive care unit that is led by Dr. Dale Needham. He's also been a champion for early activity and mobility and rehabilitation efforts among hospital inpatients, particularly in critical care. And this was a behavioral mapping project. Behavioral mapping is about direct observation of a people or a process that you're interested in. And in this case, we were looking to understand the workflow of nurses and the barriers that they might be experiencing to mobilizing their patients. And some of the key questions that I think are important to establishing a behavioral mapping project are listed here on this slide. And I'm not going to go through all of those, but I think it's critical that if you're going to do a behavioral mapping process to measure barriers, that you're very systematic up front in what that's going to be and look like. In our case, we had a physical therapist, and that was the second author on this paper, Jason Seltzer, who was that person, observe nurses and record on paper everything he saw them do in a work day. He observed 3 different nurses, a nurse with quite a bit of experience and a nurse with less experience, a nurse with 2 patients, and a nurse with 1 patient, and then a clinical technician. These were observed on different days just to get the perspective of each of these 3 different types of of providers and the work that they may be experiencing. And when he told them that he was there on the unit to watch them that day, he said that Dale wanted us to try and better understand the workflow that nurses experience on his unit. So it was an effort to see what they deal with day to day and to better help support them. So that was fairly well received, and it resulted in some really good information about what was happening to them locally and how much time they were spending doing different things. But because it was an interdisciplinary project, it also allowed us to have good conversations about what to do with what was seen. And that's where I think my last slide here is I'm going to illustrate that for the survey as well as for the behavioral mapping or whatever method is used for barrier assessment. Once it's measured, and I think it's key to do that at the beginning of a program and to do that among all the providers that are of interest for the program. In this case, AMP, that would be nurses, therapists, and physicians, although nurses tend to be the ones that we're most interested in when it comes to barriers around activity and mobility. Once you measure that, it's important to do something with that information, to review it and to make plans for how to respond to those barriers. Now, it's not as though you can always remove every barrier that exists, but often you can do things to ameliorate the perceived severity of those barriers, or to really get rid of them. Sometimes it's as simple as putting walkers or chairs on a hospital unit in the case of AMP. And so implementing those changes and letting the staff know that you surveyed that you did that is pretty key to getting buy-in, and then helping to move through the other stages of the implementation project successfully. And I put these arrows on here to circle back because I think that it's key that once you measure barriers and you review that and understand what they are and make change, that you then circle back and think about measuring those barriers again as a post-test outcome measure to see if we were able to change them, and also to maybe measure them multiple times over time to see if the attitudes and beliefs are changing, or if we are able to address them and then keep them constant, particularly because staff tends to turn over, and if you're trying to sustain a program, that's critical. So I've reached the end of my time. I look forward to any of your questions and to discussing how assessing barriers as part of an implementation project can help to make it more successful. Thank you very much.
Thank you, Dr. Young. I think we have time for one quick question before we move on to our next presentation. This question comes from Jennifer Vincenzo at the University of Arkansas for Medical Sciences. Regarding the knowledge question, I understand which inpatients are appropriate to refer to physical therapy. That was your question from your slide. What if the MD thinks he understands but actually does not? Is there a different way to measure knowledge?
Yeah, thank you very much for the question. And you know, when we get the results back from those barrier surveys, that question fits within the larger survey. And as a unit or as a hospital system, we think about that in the context of the organization, but also to look at individual providers and their patterns. And so we would start first by just looking at, do we have some sort of standards, or do we have some sort of policy that helps to inform that or guide that? And when we see differences between what people think and do and what we think is best practice or know is best practice, then sometimes we can try and target those individually. Usually you have better luck if you have nurses talk to nurses or doctors talk to doctors, physicians. And so we try to get champions and representatives on our team from different disciplines so they can address those individual questions. But often we take the score as a whole and look at the general knowledge about things and just say, do we have a knowledge problem, or is knowledge pretty good? Or do we have an attitude problem, or is attitude pretty good? And we start with that. And I think if you look at the other questions that are on the survey, I think that it will help to see the bigger picture of everything that we're considering, and then to think about a targeted approach that's both global and individual for different providers. So
great. Thank you, Dr. Young. And we have some other really good questions for you. We don't have time for them now, but I'm looking forward to getting to those with you later during our discussion session.
Great. Thanks, Addie.
And one quick housekeeping note before we move on to our next presentation, just so everyone in the audience knows, we are going to compile a folder full of references for each presentation. So we've had some questions about different articles and things, so we will make those available on the website post-institute. All right, let's move on to our next presentation, which is going to be by Dr. Miriam Rafferty. Dr. Rafferty is a research scientist at the Shirley Ryan Ability Lab and an assistant professor at Northwestern University's Feinberg School of Medicine in the Department of Physical Medicine and Rehabilitation and Psychiatry and Behavioral Science. She is also an active physical therapist clinician specializing in neurologic physical therapy. Dr. Rafferty's research focuses on health services delivery models for people with Parkinson's disease, particularly proactive delivery models. She uses implementation science methodology to study the implementation of evidence-based practices and novel technologies into real-world rehabilitation settings. She is currently funded by the National Institute on Disability, Independent Living, and Rehabilitation Research, and the Parkinson's Foundation. And Dr. Rafferty has published several articles in the Journal of Neurologic Physical Therapy and in PTJ. So welcome, Dr. Rafferty.
Hello. Thank you for inviting me to present in this session at the CoStar Summer Institute. Today I will be presenting the results of the Shirley Ryan Ability Lab New Model of Care Implementation Survey, presenting data from 3 years after the move. I would like to begin by acknowledging the study team at the Shirley Ryan Ability Lab, whose names are in orange, and the Northwestern University, whose names are in purple. Any strength and insight gained from this work reflect the work of a large team and the support of an organization committed to self-reflection. Any errors and challenges in interpreting a complex and large data set are my own. I would also like to declare the conflict of interest of salary support from the Shirley Ryan Ability Lab. To begin with the context, in March 2017, what was known as the Rehabilitation Institute of Chicago, pictured here in purple, moved to a new building and a new model of care called the Shirley Ryan Ability Lab, circled here in orange. The Shirley Ryan Ability Lab is a freestanding inpatient rehabilitation facility that is academically affiliated with Northwestern University. It also has a rehabilitation system of care that stretches throughout the Chicago suburbs and has affiliates around the world. We sit on the downtown Chicago campus, surrounded by Northwestern Medicine and University buildings, pictured here, circled here in purple. The Shirley Ryan Ability Lab has been ranked the #1 rehabilitation hospital by the U.S. News and World Report for 29 years in a row, including before when it was the Rehabilitation Institute of Chicago. When we moved to the new building in 2017, we also adopted a new model of care, a translational model with a goal to accelerate research into practice. 3 big changes were made. They included a change in physical structure with a new state-of-the-art building, lots of technology, and a co-location of clinicians and researchers. They basically took the researcher labs and desks and put them in the middle of what used to be called therapy gyms and are now called ability labs. Second, there were large organizational changes in leadership structure and professional development paths for clinicians, both physicians, allied health professionals, and nursing staff. And third, there were process changes for patients and therapists with the creation of a new role called lab therapists. Lab therapists were designated to deliver evidence-based practice delivery models, for example, high-intensity gait training, upper limb training, or aphasia therapy 3 to 4 times a week for 1 hour. Before the move, the Shirley Ryan Ability Lab began collaborating with Northwestern University Bridges program in order to study the transition. The Bridges program, which is where I did my implementation research training during my postdoctoral fellowship, is committed to facilitating implementation research and service delivery in community settings. The purpose of this presentation is to share the long-term impact of the new structure on evidence-based practice, use, and attitudes, and organizational culture around evidence-based practice and the change, as well as communication barriers that we were hoping to address with the co-location of clinician and researchers. We studied the transition in a series of 3 surveys. The first was delivered 1 to 2 months before the move. Survey number 2 was completed 7 to 9 months after the reorganization. And survey 3 was committed 2.5 years after the move, just in the end of 2019. At each one of these times, we surveyed over 1,000 participants, and there was a 65% response rate at each of the 3 time periods. One thing to note is that between the first 2 surveys, that is when the physical move and disruption occurred. Between survey number 2 and 3, more time elapsed, and other organizational changes were occurring. These included the filling of the leadership positions, establishing the new professional development pathways, just general time and settling into the space, as well as a lot of employee engagement efforts that were centered through the HR department. During the time period of preparing for the move, we spent a significant amount of time thinking about what surveys to use. We selected the surveys based on established implementation science methods to understand implementation efforts. Similar to what we know as the Rehabilitation Measures Database for rehab measures, there are 2 repositories that exist for implementation science measures. The Ready, Set, Change website is a decision-making support tool to help find measurement tools for implementation projects. This is a freely available decision support tool and is really fun to play with. I recommend going and checking it out if you have an upcoming study on some type of organizational change. Also, the Society for Implementation, Research, and Collaboration has an instrument review project that is available for members. When we looked at the surveys, we identified 4 existing surveys that we would like to use. However, each one of these surveys included 12 to 24 questions, and that was going to make a survey that we were sending to so many people very long and not pragmatic. We ended up selecting specific survey questions from the following scale. We selected questions from the Evidence-Based Practice Questionnaire, which is a questionnaire about the use of evidence-based practice. The Evidence-Based Practice Attitude Scale, specifically we chose questions from the Openness Subscale, the Organizational Change Recipients Belief Scale, the Implementation Leadership Scale. We also developed some questions of our own related to barriers in communication. Because we had so many topics to study, we adapted these surveys by shortening them. We validated our more pragmatic measures after completing Survey 1 using a confirmatory factor analysis. The results that I present in the subsequent slides are based on our revised scales, which are depicted here, and the results of the confirmatory factor analysis. If you're interested in this type of research, I would refer you back to that article. Overall, across the 3 different surveys, the respondents' roles remained consistent over time. Respondents were grouped into 5 groups based on their organizational roles: clinicians, researchers, support staff, people with a leadership role, and people with dual roles in both clinical and research fields. In this presentation, I'm going to focus on the responses of people who were primarily clinicians. So this excludes clinicians who also had leadership roles or who had a research role. We had over 600 clinicians responding at each time period. Their different role breakdowns remain consistent over time. In this presentation, I'll be sharing the results, focusing on results from the physicians in blue, the nurses in orange, and the allied health professionals in yellow. The allied health professionals is a group that included physical therapists, occupational therapists, and speech-language pathologists. First, I'll present the results of the Evidence-Based Practice Questionnaire. It's a measure that asks about how often clinicians perform various aspects of evidence-based practice, including searching the literature, evaluating outcomes, and sharing the results. Responses are on a 1 to 5 point scale, going from never using that type of evidence-based practice technique to very often. We performed an analysis of covariance for this data and the next 3 scales, and we treated the data as 3 cross-sectional samples based on the fact that there was approximately 50% turnover of clinicians by time 3. We adjusted for familiarity with the model of care and years at the organization because both of these variables also increased over time. To orient to the results, the blue line is the raw score for the physicians. The orange line is the raw score for the nurses. The yellow line is the raw score for the allied health professionals. The dashed line that is thin represents the absolute mean score across all clinicians, including those that are not shown in this graph. And the bolded dashed line is the adjusted mean. Adjusting for familiarity with the model and years at the organization, the Evidence-Based Practice Questionnaire scores significantly increased from time 2 to time 3. This finding highlights an important thing that we learned during the study, which was that we really didn't know much about how responsive these measures were to change. There were also between group differences in the raw scores, with the nurses reporting evidence-based practice use that was lower than allied health professionals and physicians. These were not significant in the adjusted models. For this graph of the Organizational Change Recipients Belief Scale similarly showed that the adjusted difference between time 2 and time 3 was significant. Examples of questions in the Organizational Change Recipients Belief Scale include things like, the patients benefited from the Ability Lab model of care, I can implement the Ability Lab model of care, I have experienced more self-fulfillment with the Ability Lab model of care, and most of my peers have embraced the Ability Lab model of care. In this measure, the physicians were lower or more neutral than the allied health professionals, and the allied health professionals were lower than the nurses, indicating that the nurses actually most strongly agreed with the benefits of the new model of care. The items that we selected from the evidence-based practice attitude scale were from the openness subscale. Questions include, I am eager to use new and different techniques or outcome measures developed by researchers. I like to use new techniques or outcome measures developed by researchers or to help my patients. And I would try new techniques or outcome measures, even if they were very different from what I'm used to doing. This scale was actually highest at time 1 compared to time 2 and time 3. However, it's important to note that across the organization, all of the clinician groups started out fairly high, around between to a moderate extent and to a great extent. The physicians, however, in this group were lower than both the allied health professionals and the nurses. Next, I'll present some of our custom designed questions on communication barriers. Responses to the question, I understand research easily, remain consistent over time, with a plurality of clinicians answering to a moderate extent. There's a very nice bell curve response to this question. Responses to the question, I am too busy to keep up to date with new clinical research, also remain consistent over time. Most respondents answered somewhere between not at all and to a moderate extent. This indicated that clinicians did not feel that they were too busy to spend time or keep up to date on learning about clinical research. In response to a question about the frequency of communication related to having a conversation with a researcher, clinician responses remained consistent over time, with most clinicians responding never or rarely. Finally, I'd like to present some of the open-ended comments from time 3 survey. We organized the comments based on the 2 questions that we asked, what are we doing well, and what are some of the opportunities for improvement? And these are some of the top comments, or top most frequently responded comment categories. One of the things that we were doing well is that people felt and recognized that there were more internal grants and fellowship opportunities to support clinicians to do research. People felt that there was greater use of evidence-based practices in our new translational model of care. And people felt that the new structure facilitated more teamwork and interdisciplinary communication. Some common opportunities to improve were that people found it hard to find time and funding to participate in research. Clinicians felt that they could use more training on research methods, and clinicians felt that we could use a better way of communicating research across the hospital between the different floors and ability labs. Some key takeaways of the study results or lack of significant results in many cases. First, the self-reported use of evidence-based practice and acceptance of the new model of care increased 2.5 years following the organization. That's a long time. More research is needed to establish responsive measures of change in organizational culture. We really know very little about the responsiveness of these measures, and our data showed that there wasn't a lot of room for movement. Finally, it's really important to note just how disruptive the organizational structure change was. Our organization has this motto in our entryway that reads that the soul moves first. This inspirational message is supposed to be for people with newly acquired injuries or illnesses who require rehabilitation. And I think that this message may also hold true that the soul of the organization may also be changing in ways that are difficult to measure at first. Hopefully, our continued culture of evidence-based practice and some of the structural changes that we've instituted at the Shirley Ryan Ability Lab will help these movements and organizational culture changes to occur in the future. Thank you for your time.
Thank you, Dr. Rafferty. We have time for a question or 2 before we move on to our next speaker. So this question is from Ellen Lee. Were the surveys repeated measures in same individuals over different timelines? If not, were they analyzed separately? I wonder if those who experienced the transition into the new model may be different from those who did not?
Hi, thank you, Ellen, for that question. That's a really great point. We chose to analyze the data as an analysis of covariance because there was a lot of turnover, and we had set up the survey behind the scenes so that we would not ever be able to link survey responses to individuals. So we do know that at time 3, about 50% of the people who took the survey were not working at the organization before the survey. So we knew that there was a high rate of turnover there. And also the 50% of people who had worked at this organization before the move, we didn't have identifiers to link their surveys to each other. So it would be very interesting, I think, to maybe just look at 2 different groups of, combined, because there weren't a whole lot of big changes between the clinician groups. I mean, maybe they were significant, but the numbers didn't look that different. It might be interesting instead to split it between people who worked at the organization before and after. So we can look at that. It's a good idea.
Yeah, great, thanks. And one last really quick question. Could you provide again the location of the Ready Set goal tool?
Great question. I will make sure that the link is in that link of resources. But if you just Google Ready Set Change, like knowledge translation tools, I think you'll be able to find it. There's an article. Let me see. The first author of the article that is about it is Timmings, Timmings. So you can look for that for the article in BMC Medical Information Decision Making. But if you just Google it, you'll find the actual site, and it's a really cool decision-making tool. Although every time I do it, it would tell me a different measure to use if I just answer a question slightly differently.
Great. Thank you, Dr. Rafferty. Your presentation builds really well on our keynote address as well as Dr. Young's presentation. So I'm looking forward to talking with all of you together during the discussion.
Thank you.
All right. And with that, we'll move on to our next presentation, which is by Dr. Jennifer Brach. Dr. Brach is the Associate Dean of Faculty Affairs and Development at the University of Pittsburgh School of Health and Rehabilitation Sciences and professor in the Department of Physical Therapy, and holds appointments in the Department of Epidemiology and the Clinical and Translational Science Institute. Dr. Brach's areas of interest include community-based participatory research, aging, gait, exercise, physical activity, and physical function. Welcome, Dr. Brach.
Good afternoon, and thank you for the opportunity to share my experience with the On the Move program with you. Here is the Knowledge to Action framework, which is guiding our afternoon session. This talk is really going to focus on the knowledge, tools, and products component of knowledge creation. First, I'd like to share with you the knowledge creation aspect. We developed a group exercise program called On the Move. We tested the effectiveness of the On the Move group exercise program in a PCORI-funded cluster randomized trial. We compared On the Move to a standard Sit and Be Fit group exercise program. Both programs were offered twice a week for 12 weeks. Our main outcomes were mobility, specifically gait speed and 6-minute walk test. At the end of the exercise program, we showed that older adults who participated in On the Move had greater gains in gait speed and 6-minute walk than those in the standard program. Our results were published in JAMA Internal Medicine. So the next thing we had to think about were what products do we need to help us with further implementation and dissemination of the On the Move program. And some of the ones that I'm going to share with you today are trademark and licensing, On the Move manual materials, a website, instructor training, and evidence-based programming. So trademark, it's really important to protect your idea or your work. Early on in the process, a mentor of mine suggested that I look into having the On the Move program trademarked. This is something I knew nothing about, and luckily I was able to draw on the expertise of the Innovation Institute at the University of Pittsburgh. It's a very slow process. We started this back in 2014, and we just found out in April of 2020 that our program was trademarked. The second part of this is developing the license for the program. And we have the program, both the program license and an instructor license. The instructor license is free for the instructor, and I really see it as a contract. And the instructors are required to sign this contract saying that when they offer the On the Move program and they call it On the Move, they're going to offer it as it is described in the manual. So they're not going to change the program, they're not going to modify it and add other things to it and call it On the Move. So it really protects the integrity of the On the Move program. The site license really allows us to keep track of who's offering the program and where it's being offered. We set up the site license in that there are two different types. If the site is non-profit, they get the license for free. If they are for-profit, there is a small fee to become registered and receive the site license. And we set it up this way, so one, that the license would not become a barrier to implementing the program at a site, but that two, if somebody is making money off the program, that we also will have some, be making some money. And that money can go into supporting further development of the On the Move program. The On the Move manual was created over multiple iterations throughout our research over probably the last 10 years. And we've received lots of input from our stakeholders on the manual. Probably the most important feedback we received from our stakeholders is they said that the manual at times was very complex and had a lot of detail. And they really wanted us to think about simplifying the manual and emphasizing what the core components of the exercise program were. So here you can see a picture of the cover of the manual and then the table of contents where we describe the different components of the program. And then at the end, we have an appendix which has different resources that the instructors can use. So here's an example of one of the sections of the program. A big portion of On the Move is walking and walking patterns. And so the first page of that section describes the purpose of the walking patterns and just some basic logistics of conducting that portion of the program. So here the walking patterns portion is typically 3 to 6 songs or 10 to 20 minutes in length. So that way that the instructors have some general guidelines. And then each of the subsequent pages show different walking patterns. And this is usually done with a figure and then also text. The other thing you'll notice is in the light blue text where it says slow/fast, these are ways to troubleshoot or problem solve through different problems that may occur when you're doing the walking patterns. And here, you know, if you're doing walking patterns with a group of older adults, how do you deal with if some older adults walk really slowly and others walk quickly? And, you know, how might you accommodate those with the walking patterns? Here's an example of some of the resources that are provided in the appendix. So first is the general tips for safe exercise. And this is something that the instructors can pull out and photocopy and hand out on the first day of class. The second thing I'm showing you here is a daily progress note. We don't expect the instructors to keep daily progress notes, but many of them ask for something that they could record what they do so that they can keep track from class to class. Also, we provide general guidelines on what each class should contain. It's not a cookbook, it's not overly prescriptive, and some instructors really like that and other instructors really struggle with it and they want a little bit more structure. So for providing these daily progress notes, they can use this to help guide them in selecting what components they want to include in each exercise class. So it provides a little bit more structure for them. And also we provide playlists in the back. So originally we thought we would set up these playlists on some type of a music sharing platform like Spotify, but quickly found that we could not do that because of music licensing issues. So what we've done is we've created playlists by listing the song title and the artist, and so that then the instructors can put these together on their own. Music is a very important component of On the Move, and the beats per minute of the song really relate to the different components of the exercise program. So it's important that they use specific songs, and we help them out with that by providing them these different playlists. The next thing I want to share with you is the is our website. I'm quite proud of our website, and a big shout out to my research team who put a lot of time and effort into developing it. Once again, we did not design it ourselves, but we worked with experts at the University of Pittsburgh. For potential participants, for instructors, and also sites who might be interested in delivering the program. Under that tab, we have links to all the research articles, so that if anybody is interested and wants to look at the evidence supporting the program, that they have easy access to it. Under the instructors tab, this is provides all the extra materials that are in the manual and also in the appendix of the manual in a place where the instructors can easily access it. This is password protected, and that the instructors they obtain a password at the training session so that they can then access this section of the website. Locations is really a database of where the program is being held, different senior center sites, and also a database of certified instructors. So if an older adult is looking for where they can access On the Move, they can go to this tab. If a senior center site would like to host On the Move, but they do not have an instructor, they could potentially identify an instructor from this database. The last tab is the contact tab, and this is where anybody can reach out to our team to get information about the program. It's also a place where instructors of the On the Move program, if they have questions about delivering the program, they can reach out to our staff and get feedback and help help problem solve through any issues that might come up. We also developed an instructor training course. This has changed over time, and we changed it based on feedback from our stakeholders. Originally, it was a day and a half, so a Friday evening and all day Saturday, and our instructors felt like we could accomplish the same goals in less time. So over the last 2 sessions we've taught, we've done it in an 8-hour, one-day course. The course or the training is very hands-on. Once again, that was based on feedback from our stakeholders. It starts with the instructors participating in a sample On the Move class so that they can really get a feel for what it feels like to do On the Move. And then we have a mixture of lecture and lab so that they're not just sitting there listening to us lecture. We do test their knowledge by a written examination at the end, and also by a practical examination. So they must demonstrate the skill in being able to deliver the On the Move exercise program. At the end of the course, all the instructors are given the materials that are needed to implement the program. So part of the On the Move program, they use balls and cones, and we give those or provide them to the instructors so that they are up and running and can teach the class the next day. I'm happy to announce that we've held 4 training courses so far, 3 in Pennsylvania and 1 in Colorado, and we have trained over 40 On the Move instructors. So the next thing I want to talk about is evidence-based programs. And for those of you who aren't familiar with the NCAA or the National Council on Aging, one of the things they do is they designate programs as being evidence-based. And these are really programs that have been proven to promote the health and prevent disease in older adults. This is a 2-step process. The first step is demonstrating that your program is effective using solid research, and then the second part is demonstrating that you have a packaged program. So to demonstrate that you have solid research, you have to show that the program is effective in improving some important health outcome. You have to do that through either a quasi-experimental or experimental trial, and your results have to be published in a peer-reviewed journal. Once you demonstrate that you have this solid research backing your program, you're then invited to go to the second stage, which is demonstrating that you have a packaged program ready for implementation. And the 2 criteria that you have to meet there is you have to show that your program is fully translated in 1 or more community sites so that it has been implemented in a community site, not just in a research laboratory. And you have to have developed the dissemination products and that they're available to the public, so that you have things like a manual, you have instructor training developed if necessary. So you can see a lot of the things that I talked to you about earlier in this talk were all in preparation to become an evidence-based program. Why is an evidence-based program so important? Well, senior community centers can access funding or government funding from the Older Americans Act, their Title III funding, and that can be used to support these evidence-based programs, which really helps with the sustainability of these programs over time. The other thing it does is that your program is then listed on the NCO website as an approved program. I will say that is how we were invited out to Colorado to do the training. Some individuals in the Colorado area saw our program on the NCO website and invited us out there to train some of their instructors. So some of the lessons that I've learned is that this is really a collaborative process. You know, we're used to doing exercise, trials, and research. I'm not as familiar with running a business or protecting a product or developing a website. It really takes a team of individuals to be able to move this research into the next stage. It's important to involve stakeholders early and often. They provided, in this case, valuable input on the training materials and also the instruction course. Don't be afraid to push yourself outside of your comfort zone. It's really these things that make us the most uncomfortable that are the most rewarding. I would tell, if you would have told me that 10 years ago that I would be where I am today, I would have said you're crazy. The idea of creating a website, creating a product, getting it trademarked is is not where I would have pictured myself 10 years ago. Also, be patient. This takes time. I will say that we first developed the On the Move program back in 2011 with a small pilot study, and it's taken us 10 years to get to where we are today. We still have a ways to go. Our next steps are we have a grant under review to conduct a full effectiveness trial out in the community with community providers, really studying fidelity with the goal of eventually moving to full implementation. And many of these products that we have created will be very important as we move forward in that process. Thank you so much, and I'd be happy to entertain any questions at this time.
Thank you so much, Dr. Brach. It's really interesting to hear about one of these projects being implemented in a community setting. Like, that seems like a whole new level of challenge. So really impressive work, and you can tell it's been a decade of hard work. We have time for a few questions. Our first question is, how is this knowledge translation and product development funded?
That's a great question. So a lot of it has been funded through I have a K-24, a career development award, to a mid-career award to help progress my line of work in implementation science. So I've been using some of that funding. Also, we charge a fee for instructors to be certified. And so some of that money covers the basic cost of the training, but it also, there's enough revenue there to help cover the cost of the website and further some of the materials. We are currently also applying for a Eugene Washington grant through PCORI for creation of dissemination products, and hopefully that will help to move this work forward even farther.
Great. Our next question is from Sean Rundell. At what stage from grant proposal development through research publication did you start planning for some of these dissemination activities, such as trademarks, website, the NCOA approval, etc.? Is there a specific point when you'd recommend planning for these activities?
Yeah, I would say for things like the trademark, as soon as you think you have an idea, I would try to meet with someone who can help you with that. It's always best to get that on the books early, and if it is too early, they'll tell you, but you don't want to be too late when it comes to having your product protected and trademarked. As far as like the evidence-based programming, that was actually, that was kind of our goal, you know, the light at the end of the tunnel. We had that from the very beginning as a goal that we wanted to reach. And so as we conducted the trial, you know, we knew we would have the publication and the science behind it, but it was soon after that we then started creating the package program. So that we would have everything that we needed to apply for evidence-based status.
Nice. So the next question is from Margaret O'Neill. Are the sites bound to send their data to you in the site license? Are you creating a large database for OTM?
That's a fabulous question. And currently they are not required to even collect outcome data. We provide suggestions on outcomes that they could use. That is another goal and another grant in progress that we would like to develop a kind of a database where we can have individuals who are conducting the On the Move program share outcomes with us.
Good. And then I think this will probably be our last question. This is from Ellen Lee. Were there specific qualifications prior to becoming OTM instructors?
So we do have certain criteria that you have to meet in order to sit and become an instructor. We want individuals who have some type of an exercise or healthcare background. So mostly PTs, PTAs, OTs, OTAs, but we also include group fitness instructors. So if someone has a certification through, say, like ACSM to be a group fitness instructor, they can also come and be certified as well.
All right, good. Thank you so much, Dr. Brach, and we look forward to talking with you during the discussion.
Great, thank you.
And as I said, I really am so, like, it's unbelievable the work you're doing in the community. I can't imagine the complexity there.
Great, thank you.
So we've had presentations across some different settings. Dr. Young was in the acute care setting, Dr. Rafferty more in the inpatient rehab setting, and then our last presentation was Dr. Brach in the community. So we're going to switch a little bit and focus on clinical practice guidelines and implementation projects focused on those. And kicking us off will be Dr. Hoeffner. He is the Regional Clinical Excellence Director for Professional Physical Therapy's Queens Long Island region. He oversees the educational development of the region's 150 physical therapists and assists in the Clinical Excellence Department's curriculum development, which is utilized throughout Professional Physical Therapy's 200 clinic locations in the Northeast. Dr. Hoeffner serves as the Director of the Professional Physical Therapy NYIT Orthopedic Residency Program, an accredited residency program with clinic locations in New York and New Jersey. So welcome, Dr. Hoeffner.
Hi, my name is Frank Hoeffner. I'm the Orthopedic Residency Director at Professional Physical Therapy, and I'm here today to discuss the current research project that we are developing surrounding the low back pain clinical practice guidelines and implementing them throughout our company. I'll give you a little background on how this project came to be and where we're currently at. So to start, Professional Physical Therapy is a company located in the Northeast. We have around 180 clinics, 540 full-time physical therapists, and we see approximately 30,000 visits per week. We have our Clinical Excellence Department is our clinical education department, responsible for education and training of our clinicians, putting on continuing education, seminars, and we also have our orthopedic residency program, and we have an affiliation with the fellowship program at Boston University. So we have a lot of educational ongoings going on within our company. This is some information on our orthopedic residency program, which is where kind of the initial ideas for this research project kind of came to fruition. Our residency program the curriculum is based off of the clinical practice guidelines. That's what we're teaching the residents, and what they're tested on. And also, we track our patient outcomes utilizing photo. We have the photo system implemented in all of our clinics. And when we started to look at the data, which you can see here, our residency graduates are above our company average. 73% of the residency graduates have outcomes that are superior to the company average. And photo ranks with percentile rankings, which I've spoken with several colleagues, and there's certain issues surrounding, is that really reflective of patient outcomes to utilize a percentile ranking? But this is what photo utilizes and what we go by. As a company, we're in the 35th percentile, and as you can see, 73% of the residency graduates are above that, and some well above that. So, what are these graduates doing that differs from the average clinicians? That's some of the questions that started to come up, and trying to see, well, what can we do? How can we elevate the remaining clinicians, or the majority of our clinicians, to improve these overall patient outcomes? That's where this project got its start. When we look at this, was a recent study looking at clinical specialization, which residency graduates go on to sit for the board exam in orthopedics, so they fall into these categories. And what was shown here is that orthopedic specialists and graduates of fellowship programs, have high adherence to clinical practice guidelines, and we've also been able to support that with our own data. It's what we see with our residency graduates and fellowship graduates in our clinics. So now, how can we take that and implement it throughout all of our clinics? And that has been how this project was developed and how it came about. I was invited to attend the CoStar conference last year, with the ideas of the project, and participated in the AOPT workshop. I came here last year, wasn't entirely sure what implementation science entailed, and after sitting through some of the initial lectures, I was really taken back at how this field of study really how important it is, and how important it was to some of the work we were doing within our company, trying to educate our clinicians and kind of drive change and get this evidence-based practice into the field. So I can't thank CoStar and the AOPT enough for having me last year. I came away with some amazing information, and it's been put into this project as it continues to develop. So our study, what we're going to do is look to utilize multiple strategies to implement these low back pain clinical practice guidelines throughout our clinics. There'll be an LMS training, which our clinicians will go through, and it will be supported by clinical champions. And who better to do that than our residency graduates that have already been formally trained and tested in guidelines-based care and with the residency curriculum. So they will be out in the field to support the clinicians and, to reinforce the curriculum in the LMS. We will also look to modify our EMR to to reflect the current practice guidelines and make it easier for our clinicians in the field to implement this information. We're very aware the easier we make it for the clinicians in the field, the more likely we are to see a change and to have an overall, positive impact. We will examine the photo outcomes and to see, is there an improvement in the overall patient outcomes in the clinics that we're implementing these strategies. And we're also going to look at clinician behaviors and beliefs to see how those change throughout the study. Do they start to improve with their knowledge and beliefs towards low back pain? And we'll use the fear avoidance back tool to assess those beliefs. The subjects, we chose to start off with a section of our company. So we will start this off in New Jersey, where we have approximately 200 clinicians throughout 50 clinical sites. There we see approximately 8,000 visits per week, with 20% of those being low back pain cases. So we're going to have a lot of data coming in, which is what makes this study, very exciting to kind of see come to fruition. It's going to, hopefully show some interesting results and data that will come out of this. So our hypothesis is that, through the LMS training and having the clinical champions in the field and the modifications to the EMR, all supporting use of the practice guidelines, that, we'll see an increase in the rate of, low back pain classification and matching it to appropriate interventions. We'll see an improvement in yellow flag identification and management. We're looking to hopefully see an improvement in the photo patient outcomes and measures, and also see that we're changing the knowledge and beliefs of our clinicians. So when we traditionally look at, and this probably came up in previous lectures throughout this conference, is the challenges that are faced in trying to implement practice guidelines and to drive change. So this was a study out of Brazil where they looked at therapists' knowledge and adherence to the AOPT low back pain practice guidelines. And what was found is that overall, the full adherence was very low, ranging from 5.3% up to 24.8% for the different classification categories. So overall, adherence is rather low, and there's, a lot of reasons for this. And, again, these types of findings are not unique to any certain practice. These are found across the board and actually, across, various disciplines. So how can we drive change, and how can we, get these changes across to our, physical therapists in the field? How do we make the right thing the easy thing to do? And that is the real challenge. What are the barriers to change? I think a lot of times we have our clinicians in the field, and they'll say it's time. They're busy. The workday is busy, and when you try to bring in something new and different, a lot of times there's resistance to it, and other reasons come up. I think a lot of times, depending on where they went to school or other training that they've had, that plays a role, along with their own knowledge and belief systems, and obviously their direct superiors that are in the clinics. What are they doing? Because they'll a lot of times model their behavior. So overall, you know, a lot of challenges and barriers that do come into play to simply getting this knowledge out there and then getting them to actually follow it and adhere to it with their everyday patient care. So again, we have these practice guidelines, and, you know, we're going to work towards implementing them. You know, what barriers and enablers, you know, do we have in order to kind of get these positive outcomes, you know, and you know, what are common barriers and enablers in the outpatient orthopedic setting. You know, I kind of just touched on some barriers, and then enablers. You know, we're fortunate at our company to have our clinical excellence department, which, you know, again, is there to support along with the residents and the residency graduates that are there. And we also have our senior management team, which is, you know, a big supporter of our current project. So, and those are key pieces of information that you need to have. So how do you drive change? You know, you need to pick, you know, multiple strategies. Just doing education alone doesn't usually implement change. We need to attack it from multiple angles. And I've starred here, you know, the different methodologies that we will undertake. You know, there'll be auditing of the charts to see, you know, are the clinicians being adherent or are they not? You know, we're assessing patient outcomes through photo, working on developing communities of practice. This is hugely important, you know, creating an environment, you know, with our colleagues. You know, again, this is where the clinical champions are coming to play, to be there to discuss cases and create this environment where, you know, everybody is learning and growing. You know, that's the type of culture that we want and that we're working towards attaining, you know, throughout all of our clinics. We have the educational materials, and we have the champions doing the outreach visit, all based on these clinical practice guidelines. So there's going to be multiple strategies utilized, including modification to the EMR. So phase one will be this pre-intervention survey. We'll use this fear avoidance back to assess clinician beliefs. Phase two will be doing the actual training. This will be conducted through LMS, and then we'll reinforce with our clinical champions or residency graduates in the field working with the clinicians, modifications to the EMR and having additional supplemental materials. Here's a kind of look at, we worked with photo to kind of get the practice guideline or the classifications put into the system so that clinicians can easily choose a category, and then they will also have some recommended interventions that'll pop up. Again, the easier we make this for the clinicians, the more likely it's going to be followed through. It's kind of an overview. You know, we'll do the LMS training throughout the clinics, EMR modification, and then kind of going to the champions, and that'll be divided up. The champions will be divided up kind of based on area, and they'll all be responsible for, you know, around 4 or 5 clinics, and to kind of work with the clinicians there to make sure that they're adhering to the guidelines and that they understand them, and, you know, understand the appropriate steps to take to implement that with their patients. Training will be based off of the, again, the low back pain clinical practice guidelines. You know, we'll rely on our residency curriculum, which we've already have and you know, revised over the years with the residents that we can easily kind of implement with them. And that'll really where we'll base the LMS training off of, and it'll focus heavily on the classification and matching, you know, appropriate interventions and the yellow flag identification, and then having the clinical champions in the field and supplemental materials for clinicians to have on hand while they're treating. This is just a look at It's from Jason Benechuk from last year's CoStar, kind of put together a little tree diagram to kind of show the low back pain, the different classification categories and the appropriate treatment interventions that go along with each. This is what we'll base kind of when we put into our EMR that we'll have, and how we'll kind of break it down for the clinicians, kind of, again, trying to give them this easy to use information to be utilized throughout the clinical day. Phase 3 will be auditing the charts to see are clinicians complying with the guidelines, or are they not? Again, roughly 8,000 patient visits a week. We'll have to conduct a random audit of clinicians to see, are they overall being compliant? And, are the educational, strategies being effective, or are they not? We'll also, in the next part, we'll be looking at the photo outcomes. Is this making a difference as far as the photo patient outcomes? Are these patients seeing better functional results or not? And then finally looking at assessing, again, the clinician's beliefs and knowledge about the appropriate treatments for patients with low back pain would be the final part that we would look at. This is just a timeline looking at how we would conduct this study, although with discussing this with some colleagues more recently, based on the number of clinics and clinicians that we're looking to include in this study, it's likely going to take more. This is going to be likely a lot more than a 12-month project. So we'll look to modify, our timeline to reflect that. But again, this is just an overall kind of breakdown that we're currently working off of. So that's an overview of the study. Again, this is still currently under development with our company and our clinical excellence department. And I'd be happy to take any questions now. Thank you.
Thank you, Dr. Hoeffner. It's really interesting to hear about research in different phases. And as you said, you're very much in the development phase. And so it's been interesting to hear about the thought process that goes into that phase of research. We have time for a few questions. The first one is from Ann Thackeray. She says, thanks for sharing your improvement efforts. Did you consider staggering your implementation strategies to see what was most effective? For example, first using education, then adding a clinical champion, etc.
That's a good question. We've been discussing, do we want to stagger some of the training based off of just in general, as far as, are we going to start with certain clinics and work out as and expand, or are we going to train all 50 clinics, at the same time? Some of it is a logistics question. As what will be, attainable for our, clinical excellence department and the champions. So we've kind of discussed, do we want to divide it up that way? We haven't thought about doing it with the different kind of strategies, as you mentioned, but that is a very good point. So thank you.
Nice, and thank you. So I think that's probably all we have time for right now, but I'm looking forward to talking more about your projects when we have all the panelists together during the discussion.
Thank you.
So next up, we have a presentation by Dr. Pam Dibblee and Dr. Amee Seitz. Dr. Dibblee has worked for Intermountain Healthcare for 14 years, has been a licensed physical therapist for over 25 years, and is a board-certified clinical specialist in orthopedics. She has managed both hospital-based and outpatient clinics within the Intermountain Health System. She has been involved in quality improvement and implementation of clinical guidelines for outpatient physical therapy within Intermountain, and in 2018, she began work as a process control coordinator for rehabilitation services for Intermountain Healthcare, involving standardization of care, quality improvement, and clinical and professional development for rehabilitation services across the system. Dr. Seitz is an associate professor for physical therapy and human movement sciences at Northwestern University. Her research and clinical focus is to optimize treatment outcomes and the health of individuals with upper extremity musculoskeletal disorders. And I will turn it over to you, Dr. Dibblee and Seitz.
Okay, thank you very much for the introduction. First, we want to recognize CoStar and the Academy of Orthopedic PT. They funded both Pam and I to attend the workshop last year for this project. So as you can see here, the title of the project is the Clinical Practice Guideline Implementation of Adhesive Capsulitis. I think we also want to acknowledge our other collaborator on this project is Kate Minnick. With the mentorship that we had with the Academy of Orthopedic PT and CoStar, we also want to put a shout out to both Christine McDonough and Joel Stevens for their mentorship. So, as you know, shoulder pain is a very common problem seen in outpatient orthopedics. It's the second or most prevalent area of musculoskeletal shoulder pain. And unfortunately, it can be difficult to treat. Data show that between 40 and 50% of patients with a new onset of shoulder pain have persistent pain up to a year. And so to improve outcomes for patients with shoulder pain, it's been shown that in other body regions, subcategorizing patients into homogeneous groups with similar findings may actually improve outcomes by matching the treatment to these particular subgroups. And this has been shown in the low back region very successfully. And so the Academy of Orthopedic PT and the APTA have invested a lot of money and efforts to try to promote these clinical practice guidelines and develop these clinical practice guidelines over the years. And so about 10 years ago, Phil McClure was identified as a leader of the shoulder guideline group, and he identified some other folks to help contribute to the development of these shoulder clinical practice guidelines. Phil has now stepped away from that role, and Lori Mishner has taken this role. The original guideline group is kind of shown up on the right. We were quite a bit younger at that age, but also shout out to Marty Kelly and Tim Uhl, who were present for that weekend of battling on trying to develop this categorization for patients with shoulder pain. And so essentially we thought that 80% of patients that are seen in an outpatient orthopedic environment treated for conservative management of their problems, so non-surgical patients, we thought that 80% of patients would fall in one of these three groups. First being the rotator cuff or muscle performance group, and these are, you can see, tied with the ICF language. Second is the instability or muscle coordination group, and the last one is the adhesive capsulitis or mobility deficit group. And so we published the shoulder pain and mobility deficits or adhesive capsulitis clinical practice guideline a bit ago, and this is really the focus of this project.
So at Intermountain Healthcare, shoulder pain is the second most prevalent non-operative disorder. Intermountain Healthcare is a healthcare system based in Utah. We have 22 hospitals from southern Idaho to southern Utah, with 39 sites that provide orthopedic outpatient physical therapy care. We have 165 physical therapists in the orthopedic setting. At Intermountain Healthcare, we use a system called ROMS, the Rehabilitation Outcome Management System. This is a web-based platform built around Intermountain's approach to continuous improvement. Each time a patient comes into a clinic, on the evaluation, the therapist classifies or subgroups that patient into a smaller group or bucket. As Amy described, subacromial pain, adhesive capsulitis, instabilities, those are some of our subgroups that we use. We use a validated patient-reported outcome, and we give that to the patient each time they come into the visit, into the clinic. And in the shoulder, we use a dash. This is collected via a tablet, so the dash is uploaded onto the tablet. Once the patient completes the dash, they click submit, the data is automatically uploaded into ROM. One of the metrics that we look at, which is one of our lagging metrics, is a failure to progress metric. and that is defined as the percentage of patients who fail to meet a minimal clinically important difference on their outcome score, in this case, the DASH. So when we look at our data from ROMS, our highest volume is lumbar conservative care. And when we look at shoulder pain, our conservative shoulder care is actually our second most prevalent non-operative disorder, third most prevalent disorder overall, with knee surgical being our second most prevalent. In 2018, we had 222 patients classified as primary adhesive capsulitis or mobility deficit. So when we look at this graph, the left-hand side indicates that failure to progress metric, and that's the blue line that you see. The right-hand side are our visits, and that's the orange line that you see. Across the bottom, we have our dates from 2015 to 2018. So if we look at our data, looking at our failure to progress numbers, from 2015 to 2017, we were hovering between 29 and 30% failure rate. And in 2018, we went up to 35.2% failure to progress rate. When we look at our visits have stayed fairly constant. We're at 7.2 visits for patients with primary adhesive capsulitis. So looking at this was a problem for our system. 1 in 3 of our primary adhesive capsulitis patients was failing. So when we identify these problems, there are certain things that we do within our system. Number 1, we identify the problem, then we try to implement a process to improve that. Typically, we standardize the evaluation and those data points that really help us drive a decision in order to establish that we're getting patients into the right subgroups. Then we determine what adherent care might look like and measure adherence to the process.
So with that problem being identified and the systems that were in place and being continually refined at Intermountain, we thought this was an excellent project to bring forward. And so utilizing that reduced or that failure to progress rate, our goal was to, number 1, improve rehabilitation outcomes for patients with adhesive capsulitis. So we decided to create the study to look at the variable of how therapists are trained and potentially the follow-up of that training. So we had 2 real specific aims out of this. We hypothesized that therapists with individualized feedback following the formalized training would have a higher process adherence to, number 1, correctly subgrouping patients with shoulder pain, number 2, identifying the correct irritability level based off the examination findings, and number 3, selecting the appropriate irritability stage match treatment. So in the adhesive capsulitis guidelines, treatment is based off of the stage of irritability. So ultimately, we thought that those with more individualized feedback and coaching would have better outcomes with a lower failure to progress rate than the therapist with the standardized process adherence education alone. And these outcomes are going to be assessed at 1 year. So if you look at the overall study design, essentially there were 39 outpatient clinics with 165 PTs at Intermountain Healthcare. And so their process, their education care process, and their education specifically for shoulder classification and the adhesive clinical practice guideline was administered to all the clinics. And Pam will go over the details a little bit more in depth on the EHR integration as well as the care process system that they implemented. At that point, we randomized then therapists into one of two groups. Therapists either had no further training or they were randomized into a personalized coaching on the process adherence and overall mentoring in areas where there might be deficits that were identified. Again, we are looking at the outcomes of shoulder classification, irritability level, match treatment, as well as the failure progress rate at 1 year.
So to implement this, we knew we needed a timeline. We needed some time to train our therapists on the process. We needed to modify the medical record to help with some decision making, and then we would need to randomize our clinics. We also had initially intended on managers providing feedback, so there would need to be a training time for managers to learn, first of all, a little bit about the process and then providing feedback. And then we would start to provide feedback and begin our data collection period. So in 2017, before this whole project came about, we had already began the process of looking at our non-operative shoulder conditions and how to improve the care. So a group of us had sat down and looked at AOPT's guidelines on adhesive capsulitis and really identified that they had identified these 3 buckets of subacromial pain, instability, as well as adhesive capsulitis. And based on that, we developed a treatment algorithm for the non-operative care of the shoulder. So on the top left-hand side, therapists were trained to and provided with this 1-page algorithm on, number 1, screening the cervical spine, then identifying impairments of body function that are related to those different subgroups, identifying irritability and what that concept of irritability means, and then how to really match your treatments to that irritability level. So we started with education in 2018 in November and completed that education in May. That was primarily on the subacromial pain group, but we had also included elements of irritability. So that was our therapist's first really exposure to this concept of irritability. Then when we look at July of 2019, we went in and did a more specific training on adhesive capsulitis. We did a 90-minute recorded session that was streamed throughout the system, so therapists would be able to join and listen to the webinar on adhesive capsulitis that was recorded by Amee. And then all of our therapists were made familiar with the clinical practice guidelines from AOPT and really learned to identify these treatment areas or these body impairments. And then we're trained on irritability surrounding these conditions. The next thing we did was we modified our electronic health record. We tried to subgroup some of our special tests into specific buckets, if you would, to help our therapists kind of see and make decisions on which tests and measures they would like to use. At the bottom of our electronic medical record for the shoulder, we implemented a specific box that indicates irritability level. We gave them some blue text so that they would be able to have a definition linked to the irritability level, or at least a guideline linked to that irritability level. We also created a classification decision box and provided them with some decision-making tools on how to determine whether this was subacromial pain, adhesive capsulitis, or instability. In that general classification, we also allowed for identifying post-surgical as well as other conditions. So our preliminary findings, when we look at our data of all of our patients classified as primary adhesive capsulitis from September of 2019 until May 1st, we had 88 patients who were evaluated and completed their treatment during that time. We went in and quality reviewed the chart to determine, number 1, were all of these people categorized correctly or subgrouped correctly into adhesive capsulitis. Number 2, we went in to look to see if irritability was identified. And then we wanted to make sure that that first treatment, the treatment matched the irritability level. So those are our preliminary findings so far, is we came in with patients who were adherent with irritability and were successful in meeting their MCID. We had 38 of those. We had 16 patients, so 30% were adherent but did not achieve a failure to progress rate. When we look at our non-adherents, we actually had 14 only successful and 20 that did not achieve their failure to progress rate. So we had a 59% failure rate there. So our patients who received adherent care were more likely to achieve their MCID success. So at this point, we did not randomize. So I'd like to talk a little bit about some of the challenges that we've had. So if you recall our actual timeline, this was our actual timeline that we had set out to be able to begin data collection. And when you look at our actual timeline, which is going to populate below here, in the black, we have our actual dates that we were able to complete the things that we wanted to have done. So our initial timeline and our actual timeline didn't quite meet up in most cases. So some of the lessons learned and some of the challenges that we've learned along the way is, number one, we set the timeline and it is delayed. There are certain things we had control over and certain things we did not have control over. So we changed our mentoring strategy as well. We had initially intended managers to do some mentoring. While this was all going on at Intermountain, we were doing some restructuring and creating a clinical ladder for some of our therapists to really go up a clinical ladder. So we were working with HR to develop a new pathway. In this process, we identified some clinical champions and decided that peer feedback was probably going to be a little bit more effective as well as efficient than probably manager feedback. So that took us quite a while to get that all in place with human resources and that restructuring of that ladder. We also had onboarded and hired about 32 new physical therapists from January of 2019 till the summer of 2019. And this was due to some restructuring. It was also due to some growth. So there was a significant change in our workforce. None of these therapists had been onboarded to Intermountain's care processes, to our ROM system, to our quality improvement initiatives. And so there was a lot of onboarding and training that needed to go on besides just the shoulder. So we spent some time onboarding those new therapists. One of the things that actually was not a significant challenge was our electronic medical record. We actually were able to make those changes fairly easily. We are continuing to provide feedback to therapists with our clinics being randomized now, and we will continue to collect our data through at least 2020, if not 2021, in order to reach that approximately 200 to 220 patient range. So, thank you.
Thanks, guys.
Thank you, Dr. Seitz and Dr. Dibblee. We probably have time for one question, and then we'll need to move on to our next presentation. So the first is just a clarifying question. Did you know the comorbidities of the patients and the potential relationship of the comorbidities to outcomes?
No, I didn't look at any of the comorbidities of patients, but it's certainly something we could go back and pull out of the EMR if we wanted to look at that.
Okay, thank you for clarifying. I think that in the interest of time, we'll move on to the next presentation, but there are more questions for you in the chat, so we will circle back during the discussion. Our final presentation is Dr. Sandra Kaplan. Dr. Kaplan is a professor, vice chair of curriculum and accreditation, and DPT PhD program director at Rutgers School of Health Professions, Department of Rehabilitation and Movement Sciences. Dr. Kaplan's areas of interest include pediatric rehabilitation, evidence-based practice and knowledge translation, clinical practice guideline methodology, and clinical outcomes. She trains CPG developers for the APTA, is the CPG coordinator and consulting methodologist for the Academy of Pediatric Physical Therapy, and is an author on the DPT Education EBP curriculum guidelines. Her current studies are looking at the uptake of CPGs into practice and education and scoliosis practice trends. So welcome, Dr. Kaplan.
Hi, I'm Sandra Kaplan from Rutgers University, and I'm pleased to be here to represent the work that the Academy of Pediatric Physical Therapy is doing in the area of knowledge translation and implementation. I'm going to be talking to you about our efforts around developing and disseminating clinical practice guidelines. So in 2012, the Academy of Pediatric Physical Therapy put into their strategic plan the goal of developing 5 clinical practice guidelines in 5 years. It was an ambitious goal. We have initiated as many topics. 2 have been completed since then. Congenital muscular torticollis guideline was first published in 2013, and its revision was completed in 2018. And this year, we're looking forward to a fall publication of the Developmental Coordination Disorder Clinical Practice Guideline. We have 4 other topics in development, 1 on idiopathic toe walking, 1 on instrumented gait analysis for pediatrics, 1 on selective dorsal rhizotomy, and 1 on improving mobility in school-aged youth with cerebral palsy. Some of the knowledge translation strategies that have been used include the traditional continuing education opportunities at national meetings, both around the development of guidelines and what those methods are, as well as on the topics of the actual guidelines. We've just recently redesigned the website to align with the new APTA branding. And in that, there's a more direct and very graphic access to our CPGs, which I'll show you in a little bit. We make all of our clinical practice guidelines free and accessible to anyone. They don't need to be members of APTA or of the section. But we do ask for people, when they go to download any documents, to register an email address and the type of profession or interest that they represent. This has given us some nice metrics on who has come to the website to access those materials. I'm also the CPG coordinator for this section, but we also have a committee to oversee the CPG processes. And we also have a knowledge translation committee that assists with producing supplementary products or tools for both the clinicians and consumers. We've produced brief summaries for parents, PTs, and physicians, and supporting information summaries, as well as educational or instructional guidelines for how to use each of those supplemental tools most effectively. And lastly, we've produced a slide deck on the 2018 revision for clinical and academic educators to use as a quick reference or to insert into their own lectures in order to update the material relative to that guideline. So this is a picture of our website, and under the Professionals tab, you can select the Clinical Practice Guidelines option, and it will take you to a list of the resources. What you'll see underneath that then are resources for parents and caregivers, and under that is the actual guideline, newborn tips for positioning and play, a resource packet for parents and caregivers, and discharge guidelines for clinicians. We have another resource packet for healthcare providers, and for clinicians and educators, a self-assessment and the PowerPoint option. So this is just an example of the 2-sided brochure that was put together for physicians. It can be downloaded as a PDF and printed on 2 sides. We encourage our clinicians to download them, print them, and distribute them with thank you notes to their referring physicians, just to make them aware of what the guidelines are and that we have produced them. This is the 2-sided panel that parents might use or that clinicians might use with a parent to help instruct positioning, ways to play with the baby to facilitate recovery and increasing that range of motion that they need. And then we also have a 1-sided format for discharge criteria that can be posted in a department or provided to parents or clinicians about what the criteria would be for discharging them from service. And this again just helps with parents understanding what we're looking for And it's been very helpful for students who are doing pediatric rotations to understand what to look for. There's a self-assessment for clinicians on the content of what's in the guideline. And again, the PowerPoint presentation is the option at the bottom. The process for developing the supplements goes as follows. Once a clinical practice guideline has reached the final draft stage, when it's being sent to the first round of stakeholders and content experts, the KT committee is also notified, and at least 2 of their members will be part of that stakeholder review. This gives them an early view of what the guideline has in it, what the recommendations are, and they can start working with their committees on the types of products that they're going to form. Typically, we expect that there'll be a parent summary and that there'll be a physician summary. We'll see what else they come up with for our next guideline on developmental coordination disorder. The committee members review the CPG, start that process of formulating the drafts, and then once they have drafts of the products, those products are sent back to the CPG authors so they can review them for content and emphasis and suggestions. And then they go back into editing and they're finalized. Our goal is to produce the CPG publication and the supplements simultaneously. So when we roll out the announcements for the new CPG, the supplements are up on the website and ready to go. Some of the methods that we use to raise awareness around a CPG is that we invite the entire membership to volunteer as critical literature appraisers, and we offer free training for that. The topics are going to be specific to the CPGs that need appraisers, so this happens periodically. And we haven't had too much difficulty attracting clinicians who are interested in taking their EBP skills to this level. The surveys that we use are sent out as part of the CPG process to validate the need for the CPG and to identify critical questions or content that may need to be addressed. We send these surveys to both clinicians and usually to parents of children who have the condition. We invite stakeholders who are appointed by the American Academy of Pediatrics to be a reader on each of our guidelines toward the end of the process. And that's a formal appointment process by the American Academy of Pediatrics. And we present on the CPG progress or content prior to its publication, usually at CSM and at the annual Pediatric PT Conference in November. We also raise awareness within the membership through our e-newsletter, Milestones, which provides invites for the public review of CPGs, and then any of the surveys that are needing people to weigh in on them, and it announces the publication and notice of the supplements. Our KBNet, or our Knowledge Broker Network, is a training process that was initiated to expand the network of knowledge brokers across the country based on the regions that we use to divide the membership. And the initial efforts were around the clinical practice guideline, although they're not used exclusively for that. And finally, we are expanding our CPG committee and guideline teams to train the next generation. One of the things that we included in our guidelines are research recommendations. And these are used when the evidence is missing, or if the evidence is weak or conflicting, or if the evidence is narrow and generalization is limited. And these recommendations have been quite successful in generating studies between the first CPG on torticollis in 2013 and when we went into revision for 2018, some of those studies were able to be incorporated in the update. The types of studies that have been generated include a survey on the uptake of that guideline into practice. There was a quality improvement initiative by Strank et al. Aletska et al. Looked at the inter-rater and intra-rater reliability of the congenital muscular tortus severity grading system. Nixon Cave et al. Looked at a qualitative assessment of clinicians and their uptake of the guidelines into practice. The article by Sargent et al. Is something that, as guideline authors, we wrote with our appointed AAP representative as a summary article for the physicians. It was published in Pediatrics so that we could make the pediatricians more aware of what their role would be relative to the guidelines, which recommendations would be most appropriate for them to focus on, and the collaborative management that PTs were looking forward to. Knudsen et al. Looked at associations between CMT severity and the episode of care, doing a retrospective chart review. And Aletska looked at a qualitative study of parents whose infants were diagnosed with mild and severe grades of CMT to look at what the impact of the lived experience is when you have a child who needs to attend physical therapy. So we've had our successes. Membership is very aware and open to the documents. There are willing volunteers for literature appraisers. And the initial uptake study indicates that PTs have changed their practice to align their exams and interventions with the recommendations. And we've had those 7 publications to date. Some of the challenges we still face is that CPG development is a long and intense process for volunteers. And finding willing and qualified authors to take on what is typically a 3 to 5 year commitment is a little difficult. Many PTs are still unaware of clinical practice guidelines, the methodology used to develop them, and how they might be applied in practice, and even when they don't need to be applied in practice. And so there's still some educating that needs to go on across the profession. And we also need to increase the awareness of our referral sources to those guidelines. So we are certainly with enough challenges to keep us busy for a while. So I thank you very much, and I'm open to any questions in the next few minutes.
Thank you, Dr. Kaplan. We do have a few minutes for questions, so if anyone has questions, feel free to enter those in the Q&A or chat features. I have a starting question. The pediatric population is just very unique because you're typically dealing with caregivers or parents. Do you think there are any unique barriers or facilitators to implementing CPGs for this population?
So one of the challenges is that when we take on a condition, often there are a wide variety of levels of severity and other factors that influence how much change you can expect. And so defining the scope of a guideline is the challenge. Do we just focus on the examination? Do we focus on the interventions? How far afield can we go? I think the clinicians have a preference for the entire management process to be reflected, and the body of literatures are quite wide, but we also don't have a lot of strong evidence. It's hard to do randomized controlled trials with infants. And so we're careful about picking the topics where we feel that there's enough evidence that we can generate at least some strong or moderate recommendations. As far as the implementation piece of it, I don't think it's any more challenging than implementing guidelines for adult care. It really is about the clinician's openness and knowledge about the guidelines, being aware. One of the biggest challenges with guidelines is that we don't have a central repository for all guidelines. You have to go to a variety of sites to see what's new or what's been updated. And that makes it a little bit more onerous to stay abreast of when a new guideline might be published, because they don't all come out in journals. And therefore, if you do a PubMed search, you're not going to find the ones that are produced as monographs by some of the government organizations.
Well, your work has certainly contributed to helping remove that barrier, at least. I have a question from Christine McDonough at the University of Pittsburgh. Can you describe your thoughts on prioritizing implementation research questions for example, CMT, CPG?
So I think when we first looked at the question of implementation, our feeling was, if we're putting this time and money behind it, are people aware of it, and are they aware of what the recommendations are, and have they changed their practice, and in what ways? And so our first survey went out, looked at both knowledge of the recommendations and how much they may have changed from before they were published to after they were published. But we also looked at knowledge brokering questions. How were they using the guidelines, and were they sharing them? And I think those are key questions because what we discovered is that while many of them had read the guidelines and aligned their examination processes, they did not feel a strong need to read through the intervention pieces, because I think that they were actually seeing changes with the interventions they were using. They were probably aligned with those interventions, so they were able to see progress. But the striking piece about the knowledge brokering is that rarely did they think to share the guideline with any of their referral sources, yet they did identify that they were getting their infants referred at a very late stage. And had they been referred earlier, this is a condition where if they're referred really early in life, it takes logarithmically less time to resolve the issue. And if they're referred after 6 months of age, it could take anywhere up to a year of intervention to resolve. And so if we could treat and resolve in 2 months instead of 12 months, there's a big cost saver and a burden saver for the caregivers. But they weren't thinking to share the guideline with their referral sources to influence the speed with which they would have those referrals. So there is some need, I think, in training and also in looking at how guidelines are used, not just in the application of the content to patients, but how are we using them to inform the whole process of referral and discharge as well.
And that sort of leads right into the next question, which will be our last question. This is from Ellen Lee. Pediatric practice has a wide range of settings. Did you have the opportunity to survey the various barriers in the different settings? And then a follow-up comment is, I felt that CPG implementation is much more challenging than outpatient settings.
So we didn't identify specifically. Typically, these infants with this condition are treated as early intervention or in private practices or outpatient hospital practices. So it was pretty limited. Typical pediatric practice in general does span a wide variety of settings, but this particular condition is unique to being treated between birth and, say, 2 years of age. So we didn't feel we needed to control for that.
All right, thank you so much.